and I will start talking about the future of the MitraClip after COAPT. So everyone knows the MitraClip system. You've seen it. You know it creates a double orifice valve by stitching together or by clasping together the anterior and posterior mitral leaflets, somewhat like the alveolar stitch, but it does grasp more tissue. This was first studied more than a decade ago now in the Everest 2 randomized trial. This was really the first randomized mitral trial in the entire mitral space, because there's been no randomized mitral surgical trials before this. So this was 279 patients at low surgical risk. But they had about 3/4 had degenerative MR, 1/4 had functional MR. Back at the time when this trial was done, we didn't even realize how different degenerative and functional MR. Only 10 years ago, but we've learned so much since then. They were randomized 2-to-1 to either the MitraClip or surgery. Surgery was considered the control arm. And as you know, this was a negative trial. First of all, the MitraClip was clearly safer than surgery. In particular, less blood transfusions and less peri-procedural complications. That was not surprising. But in terms of effectiveness, that was freedom from death, mitral valve surgery, or reoperation, it was not as successful. 72% with the MitraClip versus 88% with good surgical repair. Now, part of this was the early learning curve of the MitraClip, and outcomes have clearly improved, but this was the first trial. When you looked at all the important subsets, only one subgroup really stood out, and that was whether the patient, interestingly, had degenerative or functional MR. Patients with degenerative MR clearly did better with surgery. Patients with functional MR did similarly with surgery and the MitraClip, although this was a relatively small subset, and the fact that they did similarly might have meant that neither of them benefited, as opposed to they benefited equally, because we had no definite evidence that treating functional MR would improve patients. So following the Everest 2 trial, surgical mitral valve repair remained the standard of care for degenerative MR. However, in October of 2013, based on registry data showing that patients who got the MitraClip clearly felt better, they had better exercise capacity, less symptoms, etc., the MitraClip was approved by the FDA for treatment of patients with severe degenerative MR who are at prohibitive or extreme risk for mitral valve surgery. So the real question, though, for the last decade has been secondary or functional MR, where the disease in most cases is the left ventricle, either with ischemic or idiopathic dilated cardiomyopathy, causing restriction of the mitral leaflets, which causes tethering and lack of coaptation of the leaflets and causes secondary MR. About 10% of the cases, there can be a primary atrial component, usually due to atrial fibrillation with principal annular dilatation. So the question's always been, would treating secondary MR, where the primary problem is the underlying ventricle, would that improve the prognosis for the patient, or is the secondary MR just a biomarker of a bad LV? And we've had plenty of data to suggest that when patients develop secondary MR, quantitatively, the worse it gets, the worse the prognosis in terms of both mortality and heart failure hospitalizations. And there have been a lot of studies that have shown this. But again, until recently, we didn't know whether treating this would actually improve the patient, given that correcting the secondary MR does nothing for the underlying left ventricular dysfunction. So 2 trials addressed this in the last year. The first was the MitraFR trial, which was a 300-patient trial in France. And they took heart failure patients with secondary MR and left ventricular ejection fractions of 15 to 40% who were symptomatic. And they randomized them 1-to-1 to either the MitraClip with medical therapy or medical therapy. And medical therapy is the standard of care for patients with heart failure and secondary MR. And their primary endpoint was freedom from death or heart failure hospitalization at 1 year, and this was a real disappointing study. There was absolutely no improvement by the MitraClip compared to medical therapy alone in the primary endpoint, death, cardiovascular death, hospitalizations, or any other endpoint that they measured, quality of life, etc. And the authors actually concluded that, well, what this proves, because they had relatively high success rates of the MitraClip, is that what this proves is that secondary MR is a secondary problem, and it's not the patient's main problem, and fixing it is like fixing an epiphenomenon. It doesn't help the patient. Well, while this trial was going on, we were working through a more ambitious trial called the COAPT trial, and on its face, this wasn't that different than MitraFR. It was twice as large with 600 patients, 3 to 4 plus MR, and these patients remained symptomatic, but here we had treated them with all maximally tolerated doses of all class 1 heart failure therapies, including cardiac resynchronization. and then they were randomized 1-to-1 to the MitraClip versus continued guideline-directed medical therapy alone. And we saw markedly different results from MitraFR. We saw the primary endpoint was heart failure hospitalizations, and we had more than a 50% reduction in heart failure hospitalizations, with the curve separating almost immediately. So as soon as the left atrial pressure was reduced and the volume overload was relieved, patients felt better, they exercised longer, they had better quality of life, and they didn't need to be admitted to the hospital. And this was a big reduction, an absolute, you can see, reduction here of around 32% per year. The number needed to treat to prevent one heart failure hospitalization was 3 patients. So very, very effective. And more importantly, as we followed the patients out for 2 years, mortality was actually decreased. And you can see how sick the control patients were. Almost half of these patients died at the end of 2 years. And while we didn't cure the patients, because again, they still have severe underlying left ventricular dysfunction, the mean ejection fraction was 31%, we did markedly reduce their mortality from 46% to 29%. An absolute 17% reduction. The number needed to treat was about 6 to save 1 life. We looked at multiple different subgroups, pre-specified and non-pre-specified, to see if, looking at, for example, death or heart failure hospitalization, there was any subgroup that didn't benefit, and we couldn't find any. Men, women, younger, older patients, low surgical risk, high surgical risk patients, lower, higher left ventricular ejection fractions, they all benefited. And to try to put these results into perspective, if you look at the patients who had HFrEF, that is an ejection fraction less than 40%, for all other Class 1 guideline-directed medical therapies, to save 1 life, you have to treat somewhere between 20 and 50 patients. In the COAPT trial, we had to treat 5 patients to save 1 life. So this is dramatically effective, more so than other medical therapies. So why are the differences of COAPT and MitraFR so different? Well, probably the #1 reason is that the COAPT trial enrolled patients with substantially more mitral regurgitation and substantially less left ventricular dilatation. So the hemodynamic severity of the MR was substantially greater. This has been nicely discussed by Paul Graeber and Milt Packer. They came up with the concept of proportionate or disproportionate MR, relating the left ventricular end diastolic volume to the effective regurgitant orifice area. And this black line here is severe MR. And what this means, proportionally severe MR is basically garden variety severe MR. The red zone here is very severe MR. That's disproportionate MR. And then the green zone is non-severe MR. Another way to think about this is that this situation of proportionate MR is where both the severity of the MR and the left ventricular dysfunction are contributing importantly to the patient's symptoms and prognosis. Up here is MR dominant, and down here is LV dominant. And you can see COAPT, on average, had much more severe MR and less left ventricular dilatation than the patients in MitraFR. And of course, that was the mean values, but there's a cloud of patients around each of these studies. And in general, there were a lot of non-severe MR patients enrolled in MitraFR and very few very severe patients, in contrast to COAPT, where most of them had very severe MR. So these are patients, 3 patients with an EROA of 30 millimeters squared, and despite that, you can see 1 patient's got essentially normal ventricular size. Obviously, this 30 millimeter squared EROA is going to be very impactful here. You would expect this patient to be benefited by MR correction. This patient, on the other hand, has a left ventricle that's twice the size of normal. For the same degree of MR, he's not going to benefit. So it's just that MitraFR enrolled mostly these kinds of patients, COAPT enrolled mostly these kinds of patients. The second reason is that in COAPT, as I mentioned, all the patients had failed alternatives. They failed other guideline-directed medical therapies, and they basically had nowhere else to go. In the MitraFR trial, there's evidence that they treated the control arm more strongly because they were not yet on optimal medical therapy. So they had more heart failure medications, which kind of biased the trial to the null. And finally, the US and Canadian sites had tremendous experience in 10 different studies with the MitraClip, whereas this was the registration trial in France for the MitraClip. As a result, the success rates were higher in COAPT, the complication rates were lower, and most importantly, at a year, there was only a 5% severe MR recurrence rate in COAPT compared to 17% in MitraFR, in part because more clips were used in COAPT. So on the basis of this, earlier this year, the FDA approved the MitraClip for patients with severe secondary MR who remain symptomatic despite GDMT. They basically looked at all the subgroups of patients in COAPT and couldn't find any subgroup that did not benefit in terms of prognosis, and the label basically reflects the COAPT inclusion criteria. So in summary, COAPT and MitraFR provide complementary guidance for patient selection, demonstrating which patients with heart failure and MR are likely and unlikely to benefit from MR reduction. The FDA approved the MitraClip for secondary MR following the COAPT criteria, and if you follow these criteria, you'll treat the right patients and avoid overtreatment. And finally, ongoing and future trials investigating surgical and transcatheter mitral valve repair and replacement techniques and devices in heart failure patients with secondary MR who meet COAPT criteria must include the MitraClip as an active control arm. And those trials are underway right now. Thank you very much.